Nice chatting with you.
Hello, everyone, and welcome to today's webinar titled Keynote Presentation, Expanding Access to Compassionate Evidence-Based Treatment for Opioid Use Disorders. This webinar is part of the Opioid Crisis event, and I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to participate by communicating with other attendees using our new live chat feature during this presentation. You can find that live chat located at the right of your screen. You can also participate by submitting as many questions as you want during this presentation. So to do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the continuing education credits link located at the abstract window below the presentation window and follow the process to obtain those credits. If you have any trouble seeing or hearing this presentation, click on the Help Desk button located at the bottom of your screen with the navigation bar or from the lobby. I now present today's speaker, Dr. Jennifer Sharpe Potter, a Vice President of Research, Interim Research and Professor of Psychiatry and Behavioral Sciences at the University of Texas Health Sciences Center, San Antonio. For a complete biography of our speaker, please visit the Biography tab at the left of your screen. Dr. Potter, welcome. You may now begin your presentation.
Thanks so much, and thanks to LabRoots for inviting me to participate in this important topic. I find myself more and more, anytime I get an opportunity to speak about opioids and substance use, I try to make it there because I'm just actually very excited at the opportunities that is afforded by the awareness that's growing in the United States over the past 10 years related to substance use disorders more broadly. So what I'm going to do today is utilize some of the work that we've been doing in Texas to tell the story of how we can impact opioid use disorder, reduce morbidity and mortality related to substance use disorders. And a couple things before I get started. What you'll notice is I sometimes go interchangeably between substance use disorder and opioid use disorder. And that's really because, from my perspective, we aren't in the midst of an opioid crisis. We're actually in the midst of a substance use disorder crisis that results from a lack of understanding of how to treat opioid use disorder, and generally our country's discomfort with talking about substance use in general. And so hopefully my perspective on this will give you something to think about as we go on with our days, and a little bit maybe that you'll be doing a little bit differently in whatever it is that you guys do in your day-to-day around substance use. So my story begins a few years ago. I was trained as a researcher. I'm a clinical psychologist. I have spent most of my career conducting clinical trials, randomized controlled trials, the gold standard for treatment development, both with behavioral treatments and medication treatments, and some devices as well. And a number of years ago, I realized that I needed my work to change because while I love developing treatments and working on this aspect, what I was realizing was that there was a significant problem between what we developed in the research environment and it actually translating out into the community in a way that was meaningful and that would make impact. And in the face of this staggering number of deaths and illness associated with opioid use disorder, it was really hard just to not take action on that. And as a result of that, I started to have some conversations with leadership in Texas Health and Human Services, which is our state health agency in Texas. And I got kind of the opportunity of a lifetime to be able to translate some of the work that my field of substance use disorder research does and see whether or not we can actually deploy this in a thoughtful way in Texas to mitigate the issues we've had related to opioid use and opioid use disorder. So that's my story, and I'm going to walk you through it. And I'm hoping out of this you'll be able to take something away of use to you and think a little bit differently about it. So I've already made a mistake. Excuse me. There we go. So the first thing I wanted to let you know, because my story begins with funding, like many people, I'm only able to do the work that I'm funded to do. and I'm the benefactor of a number of awards, both from, as you'll see here, from the National Institute on Drug Abuse, where we do clinical trials, and then also our Texas Health and Human Services contracts. And if you look at this, normally this would just be an acknowledgement of my funders, who, by the way, don't endorse anything that I'm going to say. Everything that I'm saying today is my opinion based on my experience and expertise. But you'll look at these projects, and I have a number of them from Health and Human Services, and that's typically how it works, right? You go ahead and you look at different programs and you take advantage of the funds that are available. But what we're doing in Texas right now is we have an overall framework that I'll be sharing with you today. And we're really looking at how, utilizing diverse funding, we can actually work towards improving the system of care for opioid use disorder and more recently for substance use disorder in the state of Texas. And we really believe that transformational change is possible, even in the face of great challenges. And that we'll be able to reduce morbidity and mortality related to opioids and substance use disorders. So compassion is a word that gets thrown around a lot lately. People are passionate about this and they care about compassion. And because it's in the title, I thought it would be useful for me to share what compassion means to me. And this is a definition from a dictionary. Compassion is to recognize the suffering of others and then take action to help, or a tangible expression of love for those who are suffering. And so compassion is really different than empathy, and sometimes we use them interchangeably. I like to think of compassion as a verb, and I take note of the take action to help. And so expanding access means that each of us in our own way has to take action to help. If we're going to be able to give people access to the very best care possible, we need to have compassion, because that's that action part of this. It's too often the case that the healthcare system and society more broadly, and in fact, even our own selves very often, really fail people with a substance use disorder or an opioid use disorder, because it makes us uncomfortable. It's something that is stigmatizing, that people are uncomfortable talking about. When someone has cancer, people reach in and talk to that individual and tell them to fight that cancer, and they're bringing casseroles and really leaning into the family and the individual who's experiencing that cancer event. That doesn't really happen with addiction. It's very often the case that people are left entirely alone to work on these issues. That stigma can actually be lethal. We know that one of the reasons why people don't seek help for a substance use disorder, particularly an opioid use disorder, is because of the self-stigma and fear of shame and stigma from family and from treatment providers. And that stigma can literally kill in that instance, because it's a barrier to people getting their treatment. Nora Volkov has said, as you see here, it is incumbent upon clinicians to address this and to meet the unique needs of individuals. And so we can't just talk about using treatments that work. We have to talk about compassion and the action it takes to get those treatments out into the community and make sure that everyone has equal, equitable access to the very best care. The other part of what I talked about in our title is evidence-based treatment. And when I say that, I mean treatment that works, treatment rooted in science that's going to help us give the very best opportunity for a recovery from a substance use disorder. Because the good news is that substance use disorders are treatable. Not everyone requires treatment. People will go on to remit from a substance use disorder on their own. That's not always the case, and it can be high risk. And so it's often very useful for people to seek treatment. I'm biased. I believe in treatment as a pathway to recovery, but we have to get them there. So to start off, I want to give you a video, and we'll watch this, and then we'll chat a little bit.
I was using heroin for around 6-7 years before things started to catch up. I didn't know who I was. It just changes your brain chemistry, and it changes who you are so much. I was a little girl. I was a little girl and just a shell of myself. My name is Sherry. I grew up in Massachusetts. I'm currently in school for biomedical engineering, and I'm raising my 7-year-old daughter. and we also have a dog. When I came into treatment, there was just so many pieces to work on. And, I'm this tiny, frail girl, and I had never really learned any of the skills needed to function in life. I was scared. I was afraid to ask for help. I was afraid to talk to anybody. And I've been fortunate. All of the people that I've worked with, from the front desk to nurses and doctors, everyone has always treated me the same. They've seen me change. I look nothing like I did before. I speak nothing like I did before. We change so much profoundly. And my nurses and my doctors are right on board with that. And, they always ask me, how's school going? How's this going? You've come so far. Remember when you were in that shelter and now you're in this house, and, you're doing such a good job, and it means so much. Sometimes we don't have people to tell us that.
So a couple things about that video. To me, we don't need to talk about compassion. We actually need to do it. And you could hear in the words that Sherry was describing that she met with compassion. No one in that treatment system, as she described it, said, hello, I'm going to give you compassion, or I'm being compassionate in doing this. But embedded in the way it was approached was compassion. It was breaking down barriers. It was helping on that journey. It was providing support and believing that this individual had the dignity and the capacity to affect their own recovery and the change. In this particular instance, this video is from PCSS. So the woman that you saw was receiving buprenorphine medication that's approved to treat opioid use disorder as part of her care. And as you heard her, you also heard her describing herself looking nothing like she did before. So I would venture to guess that for many of us, if we had seen Sherry as she was presenting prior to her treatment, she would be unrecognizable in some ways to us relative to how she presents now. But that's a good illustration of how we make judgments and we stigmatize people based on the symptoms of their disease, rather than evaluating them as someone deserving of care and having the opportunity for treatment success. So a little bit about addiction and substance use disorder in Texas. It's very hard right now to think about opioid use disorder and not really think about it in the context of the pandemic, because unfortunately, at a time, excuse me, in our history, when we are spending a tremendous amount of resources, arguably not enough, but much more than we have previously, to mitigate the problems that we are seeing in the United States with opioid use disorder. In 2020, we actually saw an increase in opioid-related overdose deaths and a concerning increase in deaths related to methamphetamine as well. That's the wrong direction, particularly when the public health infrastructure of the United States is working actively to reduce the number of overdose deaths. We saw them go up. And most people would argue that in some ways that was probably a result of existing factors and failures, but also a result of the problems presented by the pandemic, both in terms of the restrictive access to treatment in some areas, as well as the, excuse me, as well as this idea of social isolation and other mental health issues that seem to have emerged as a result of the stress that people have been in during the pandemic. So I hope as I've been talking, you've been taking a look. I'm going to use Texas as my example. So you'll see here, these are the things that I worry about. The 1.65 million Texans who have a substance use disorder, alcohol, or other drugs. The fact that 1 in 10 people who need treatment, only 1 in 10 ever receive that treatment. and even fewer receive evidence-based care, that treatment that works that I was talking about earlier. A lot of places offer treatment. Not as many offer treatment that's rooted in science and based on the very best evidence. Those clinical trials that I was describing that I learned as and conducted in my career. And 75,000 additional deaths have been attributed in the United States that won't be counted in those overdose deaths because these are associated with that, including suicide and alcohol use in the pandemic. So what that leads us to believe, and this is a reporter, Alyssa Klein, talking about the loss of her brother, David, recognizing the fact that that many of the losses that we have experienced as a country will not be counted in the death toll of the pandemic because these things happened. And this is the story of her brother. She's a reporter, and he unfortunately died of an unintentional opioid-related poisoning in 2020. To give a little bit more information about this in the context of the pandemic, I just want to point this out. This is data that the Centers for Disease Control reported in 2020 of last year, and it was at the very beginning of the pandemic. And I want to point out a couple things in that red box. This is a question related to whether or not someone had started or increased substance use to cope with pandemic-related stress or emotions. So what we're seeing there clinically is a functional relationship between substance use and managing stress. And that really, for me as an addiction expert, is a concern because that's when we start to see that substance use starts to become a solution to stress. And in some cases, particularly for individuals who go on to develop a substance use disorder, it sort of begins to be the only tool in the toolkit of coping. And that's really that insidious setup for a substance use disorder. And I'll just point out one age group between 18 to 24. 24%, 1 in 5, reported starting to use or increasing substance use to cope with the pandemic. That's not the type of numbers that we want to see. And it's one of the concerning things that we have is that perhaps as a result of the pandemic over the next several years, we'll see substance use issues in the United States getting worse. So it won't be just opioids, it will be all substances. And we're starting to see early signals of that now. And that's the reason we're doing some of our work. Additionally, I'm going to point out if we look at that same survey and we look at the characteristics by race and ethnicity, I'll point out to you that some groups seem to be disproportionately using substances to cope with stress. And these rates parallel some of the issues we've seen with the pandemic in terms of the disease burden of COVID-19 as well. So in my area, I live in a majority Hispanic community or Latinx community, and here we see 1 in 5 reporting using a substance to cope with pandemic stress. So this is the types of things that we watch and we get concerned about. So I'm grateful to those of you listening today to think about how we're going to be contending with this moving forward. The other piece that's important is even if we reject the notion that substance use is a primary focus of our day-to-day lives, that's not really something that interests us. If we're interested in other issues that impact public health, that impact our social justice issues in the United States, we have to talk about substance use disorder. Substance use is proximal in suicide. We know that completed suicide often has substance use involved in that suicide completion. We know that substance use increases the risk for a sexually transmitted infection, including HIV and hepatitis C. We know that alcohol use, for example, is a particularly common cause of cancer. And that's something that most people in the United States simply don't know. I'm often, I go to cancer benefits as part of my work, and when that comes up, you can see people rethinking that glass of wine. And it's not to say that all alcohol use is bad. It's just for us to understand and begin to have conversations around the role of substances and its contribution to disease. Criminal justice, which is in danger of becoming the de facto treatment system for substance use in the United States. child separation from family as a result of substance use. All of these things are things that weigh on us. And so that intersection between substance use really places it at the crossroads of a lot of public health issues beyond even just mental health, which is something that we probably recognize more with substance use. So, welcome to Be Well, Texas. We're very glad that you're here. This is our program to address substance use in Texas. We have created a virtual community, if you will, a place where people can come and get access to treatment and any other positive change that they see related to substance use for themselves. So we've created this vision to represent a different way of talking about substance use that welcomes people, because we're very glad when people call us. We're so grateful to be a part of the conversation that they're going to be having with themselves about what to do about substance use when they recognize there's a problem. And I'm going to tell you a little bit more about our system of care that begins with all of those grants and funding that I started with from the state of Texas. So our mission is to expand equitable access to evidence-based programs, those programs that work, that are rooted in science, that the best possible methods have demonstrated that this particular program or intervention works. It's grounded in compassion, rooted in science. And another novel piece of what we're doing is that it's improved by technology. So in our programs, we include people with lived experience of recovery. These are people who have or have used drugs, addiction medicine specialists, behavioral health experts like myself, and health IT innovators, all coming together to create Be Well, Texas. In doing this, I'm a scientist. We are creating a learning healthcare system. And the process behind this is that we start with science. Our research is influencing how we practice and what we do in our work. We are continuously evaluating our work and adjusting the treatments that we offer as a principle that underlines our work. And then we share that work, which is part of the reason why I'm here today talking about Be Well, Texas and this place that we've created. And so it's a continuous process of improvement informed by the research that we do. The model that we use is the translational science benefits model. So again, we don't just start programs, we actually apply the conceptual framework around what we do. This particular model comes from the field of translational science. A lot of work has been done to address opioid use disorder in the United States. The biggest public health failure related to opioid use disorder in the United States is that we failed to effectively translate all of the innovations that we know works, all of those treatments that we know are effective. We failed to get those into treatment programs. And as a result of that, people died. And so the work that we do is anchored in this idea that we need to have resources, but we also need to engage in science. And the products of that science and how we get them into practice are an essential part of the work that we do. So in our team, we have dissemination and implementation experts, implementation scientists that help us with this and study this. But the work is always focused on those 4 colored circles at the end, which are the benefits of translational science. It's impacting clinical care, it's impacting the community, it has economic impact, and that policy changes are associated with the very best science being translated into practice. We drill down a little bit further. So on that previous slide, you saw those 4 colored circles: clinical, community, economic, and policy. This is our organizing framework for what we do. And I want to point out that in that interior circle is a framework for how we actually get effective practices. That's that green circle. And outside of that is a yellow band or a yellow circle encapsulating that maintenance. So we start at the center with this blue circle in the center. Forgive me, I don't know if the pointer works. We start in the center here with the evidence-based intervention components, and then we build on that with these processes: health equity, costs and resources and capacity and dynamic context and culture are all critical to us being able to do this work. We want to make sure that the care we offer is equitable, that people have an equal access to this care, and that we're always pragmatic because we understand that there are limited resources with which to work. So this is our model by how we do that, and I'm going to show you. a little bit more. So these are the initiatives. So all of those funding programs that we have, we put into a set of services that we identified as complementing the existing ecosystem of substance use in Texas. And then we said, where are the gaps? What do we need to do? If we had several $1 million or tens of millions of dollars, in this case, close to $100 million, what would we do with that to have the biggest impact and not take away from the existing effective programs that already exist? So our project connects Texans to life-saving treatment. We have treatment networks both in the outpatient level as well as in the hospital setting. You'll also see that the second leg of our three-legged stool is a virtual clinic. So our first leg is our treatment networks, our provider networks. Then we also have a virtual clinic. This is a statewide clinic that anybody, regardless of their ability to pay, even without insurance, can access so that they can get treatment as close to on demand as possible. And I'll talk a little bit more about that in a minute. We leverage technology for this. And then that third leg is telementoring. I can have a virtual clinic that offers treatment to some. I can build a treatment network to offer treatment to more. But if we actually mentor healthcare providers, physicians, nurse practitioners, physician assistants to treat substance use within their own practices, then we've really got something, because we have this network of people that are willing to treat. And then we complement that with the specialty care that we offer. So I'll show you a little bit about that. So our provider network. Provider network here in this case is a network that we've built over time. All of the treatments that we offer are evidence-based treatment, but we're not doing that ourselves. We're identifying local communities, local stakeholders, and local providers and contracting with them to be able to provide the treatments in that community. We're then providing them with the training and technical assistance so that they're better able to deliver this care to the standards that we would want to see to make this truly evidence-based. So in our technical assistance, we provide tools and resources and strategies to help build that capacity. And then we're working with them to have clinical process changes in their workflows and how they work to be able to do that. We monitor all of what we do. There's an evaluation backbone in this because the outcomes are the most important thing. We're showing that by using evidence-based practices, programs can actually improve the quality of care, the program efficiency, and have better patient outcomes. It's not hard to implement evidence-based practice. The technical assistance is intended to make it stronger. We are building this network of providers throughout Texas because there are areas in our community, just like in all of the United States, that really have very little access to service. So we have treatment deserts. And so these local networks help us to bring that into the system, and the technical assistance ensures that those folks are more comfortable engaging in this treatment and treating opioid use disorder because they have that specialty technical assistance. And then the last thing we do with our recovery support is our recovery support services. In this, we're actually utilizing, as we've mentioned earlier, people with lived experience. Peer recovery support specialists are people in recovery who are trained professionals in recovery support. This is an entire workforce that's being built in the United States, utilizing people that can hold out that hand, using a structured approach and be able to complement what a healthcare provider does. A doctor really only sees a person with a substance use disorder for their clinical visits. A peer recovery support specialist helps that individual with the exoskeleton, if you will, to be able to support what they're doing in terms of their long-term recovery. People can quit substances every day. To maintain a change in your substance use requires additional support, because it's often the case that when somebody changes their use of substances, the old networks that they used to have, the old communities, the places, the people, can become challenging for them to deal with if they're trying not to use substances. And so peers are people that can help connect them to new ways. It can help address criminal justice issues. It can help individuals get work again and go to meetings and do other things. And so that's why we bring the peer recovery support services as an essential component of our provider network. So right now we have 4 provider networks. We have our medication-assisted treatment, or as I sometimes call it, medication for opioid use disorder or medication for substance use disorders. Right now, we are providing services through our network for evidence-based treatment for opioid use disorder, alcohol use disorder, and we're working on stimulant use disorders based on some recent evidence that's been published about the use of medications to treat methamphetamine and cocaine use disorder. We have a hospital network. Hospitals historically have not been thought of as opportunities for care, and there's really a missed opportunity there, both in individuals who are hospitalized and also people presenting at the emergency department. Those are moments of opportunity when an individual is hospitalized and identified as having an opioid use disorder. We should be providing them an opportunity to begin their treatment, to initiate care for that opioid use disorder, and then finding them opportunities and outpatient placement that's easy, that's simple, that's not complicated, that provides warm links and to care so that they're able to continue that care the moment they get out of the hospital. So that's our hospital network that we're building right now, and I'll show you some more information on that. We also have the peer recovery support network that I mentioned. We have the entire state of Texas, 254 counties, covered by 12 recovery support specialist organizations that we contract with that are able to provide that support in that region. What's very exciting with that is we're really working to utilize technology to expand their reach, particularly in outlying areas where it's not as easy for a peer to travel to meet an individual and have a cup of coffee, to talk with them about plans. So being able to provide telerecovery or recovery using technological solutions like the phone or a video chat really can be a game changer in terms of providing access and engagement. And then our emergency response hub, and I'll tell you a little bit about that in a minute. So this is our recovery network through Texas. You get a chance to see if you haven't been to Texas. We are a very large state. We have 254 counties. Some of those counties do not have a physician. And so we are challenged when we do this work to really understand how to be able to build this network. So we have outpatient opioid use disorder treatment offering buprenorphine as well as injectable naltrexone. Those are two of the three medications used to treat opioid use disorder, methadone being the third. So we have 15 methadone providers throughout the state of Texas that are providing this care. All of this is for individuals that would not otherwise be able to get treatment. Texas does not have Medicaid expansion, and as a result of that, there are many individuals that do not have the ability, even through Medicaid, to be able to access services. And so as a result, we have people just without insurance. These funds pay for both the medication as well as the medical visits associated with that. We have over 11 recovery support hubs that I mentioned to you. We also have our disaster programs that I'll mention to you in just a minute, and those are those 7 hubs in the blue and green. And what I'm trying to demonstrate with this is the breadth of what we're doing and what we're trying to build. Because if we're going to transform substance use disorder and opioid use disorder in Texas, we can't just do that from behind a computer. We need to get out into these communities, and this provider network is really the backbone of that. This is an example of our partners. We have a very diverse set of partners, public and private organizations, for-profit, nonprofit, programs that have been in communities for a very long time and some that are standing up. We have academic partners using largely the UT system, as well as other universities in Texas. Our medical schools have been extraordinary partners in this. And this network is to build that tent, because to address substance use disorder, for all the reasons that I mentioned, we need a really big tent, and we want to have as many partners involved and funded by the work that we're doing as possible. So I mentioned our hospital network earlier, and I wanted to give you a couple examples about some of the work in detail. What this hospital network does, and we have a program called Shout that is conducted in large part with the vision of Del Seaton Medical Center at UT System in Austin. This program supports early intervention. So it's an opportunity when an individual with an opioid use disorder is identified in a hospital setting to be able to provide them the opportunity to get access to buprenorphine. And so the teams that work in the hospitals, and I'm showing you an example of the initial pass at these, this is our first cohort, are trained. to be able to provide buprenorphine. It is not complicated. Sometimes with substance use, we make treatment so complicated that in and of itself is a barrier to actually affecting change. And so this is a simple way to introduce this level of care for opioid use disorder, just like a hospitalist in hospital medicine would provide care for anything else. The individuals started on buprenorphine, and then there is a referral program so that these individuals can have rapid access to follow-up care in an outpatient environment. And that's the true measure of success. So you take the hospital, that moment when somebody is hospitalized, as a moment of opportunity, and then move from there. So we have another new program. That's one piece of it, and it's great that we're doing that. But really, as I mentioned, we need to have treatments for all substance use disorders, and hospitals are almost opportunity moments for more than just opioids. And so we have a new program that we're starting. This is a screening, brief intervention, and referral to treatment. SBIRT is the acronym. This is the idea that if you can screen individuals for a substance use disorder using very brief screens that do not disrupt clinical care, and provide them with appropriate referrals when a substance use disorder is identified that requires treatment, that we're able to make those referrals as well. One of the exciting pieces about this is that it's giving us an opportunity to work in a pediatric setting, because substance use disorder and opioid use disorder do not start at the age of 18. It starts not even at the age of 16 sometimes. It actually, people's first exposure to alcohol and other drugs is really quite young now in the United States. So it's not uncommon to see individuals starting to use substances in middle school and earlier, unfortunately. This program provides us an opportunity to identify that in a hospital setting in a pediatric hospital, and then provide referrals specifically tailored to the needs of young people. This is a critically underserved population in the United States. So the lessons that we learn from this in our learning healthcare system, we will hope to be able to disseminate more broadly. Another project that you've seen on some of the slides, and this relates to that second leg, that virtual clinic that I'm talking about, was really the result of an opportunity to respond to two disasters. The first disaster was COVID, and the second disaster was some of the hurricanes and coastal flooding that Texas unfortunately experiences from the Gulf. So this is along the coast, Houston north and south along the coast of Texas. And so we sat there with this challenge of trying to think about, well, what would be the thing that we would want to do with several $1 million to be able to help an area or a region, in the case of COVID, the entire state, in the case of hurricanes and flooding, the coast of Texas, along the Gulf Coast. What we identified was that the existing infrastructure was struggling to meet the demand for substance use disorder services. And so in this particular case that this is talking about, this was along the coast. And we identified an opportunity and said, well, we're going to do something that complements what's already there and then build something a little bit bigger. And the result is our virtual comprehensive services. So this, for those familiar with a stepped care model, is somewhat similar to that. And it begins at the foundation, which is a 24-hour navigation hub and crisis support call line. This call line and navigation hub is web-based. I'll show you the website in a moment. What this does is it provides us with the opportunity to have a place for people to call if they're concerned about drugs or alcohol, either for themselves or their family. The line is staffed by those peer recovery support specialists that I mentioned to you earlier. That's a backbone of what we do, is having peers involved. And they're able both to talk to somebody who's wondering if they're having an issue or perhaps has recently relapsed. But then they're also there to say, hey, are you interested in treatment? One of the biggest barriers is, again, finding treatment. And so these individuals are able to say, well, we can connect you to our program, and they can receive as close to on-demand as possible treatment offerings directly from that. So if you imagine it, it's a call connected to triage, connected to care, connected to visits. And because it's virtual, an individual does not even need to leave their home or the place where they're calling from. This includes medication services as well as the initiation of buprenorphine for as long as we're allowed to do that. We're currently able to do that because of some of the loosening of the regulations around buprenorphine. So we will start somebody on treatment for an opioid use disorder if it's appropriate after thorough evaluation. But low barrier, we're able to do that over the phone. Last week, we had an example where an individual called. They were appropriate for treatment with buprenorphine for an opioid use disorder. But the physician at our clinic, the Be Well Texas clinic, felt like it probably needed another person's eyes on them before they were willing to do that. So this individual actually went to their primary care doctor and said, hey, I have an addiction medicine doc who wants to start me in treatment. Can I do that from your office so that we're sure that it's safe? And so it was a really great partnership where someone that we'd never met before until that visit was partnered with their primary care doctor, who, again, we'd never met before. But through consultation and liaison in a video visit, we were able to start that person on life-saving treatment using buprenorphine. And as a reminder for those of you who may not know, the treatment initiation on buprenorphine has an incredible impact in reducing morbidity and mortality associated with opioid use disorder. So it's a nice example in practice of what we're trying to accomplish with this goal. So that's that treatment and care coordination piece. And then because of the pandemic and the strain that dealing with the pandemic has placed on healthcare workers and the stress that they've experienced, we are seeing an alarming increase in the use of substances and mental health issues among healthcare workers. So we have a particular carve out for specialized peers and services and treatment available for healthcare workers as part of this program as well. So this is the website for Recovery Texas. We have this program. We're currently staffed. This is all very new. We're currently staffed from 9 a.m. to 9 p.m. and we're going 24 hours within the next 30 days. And this is a place where people are able to get help immediately and have someone speaking to them, chatting, or and being able to communicate with them in real time. And then that last, So this, and then the third leg in our third-legged stool is that telementoring. So we are standing up a telementoring institute to encourage primary care providers, other specialties to become involved in treating substance use disorder and reducing the morbidity and mortality and ending the overdose crisis, or the opioid crisis, which is the name of this meeting, by providing appropriate mentoring and support and specialty care consultation for those who would be willing to treat substance use disorder. So this, again, is a no-cost telementoring institute to support improving treatment outcomes. We offer practice-based, culturally responsive approaches to care. And the intent is to advance the quality of care and the skills and competency of healthcare workers broadly defined. So physicians to EMS first responders, nursing staff, medical technicians, behavioral health workforce, to increase access to substance use treatment so that when these individuals come into contact with someone with a substance use disorder and an opioid use disorder, they're able to respond with the very best care and know that they've got referral systems in place and the consultation liaison with experts in opioid use disorder. So these are a variety of activities that we do. The anchor platform for that is a program that was developed out of the University of New Mexico called Project ECHO. Project ECHO is a video-based mentoring, consultation liaison support service. It's HIPAA compliant, and it provides us the opportunity to engage individuals. So in our programs, we have a buprenorphine community of practice where individuals can join our mentoring program. There are twice monthly community of practice sessions where didactics about getting started with buprenorphine treatment or complex cases. For example, we've had conversations around treating hepatitis C in the context of opioid use disorder, or benzodiazepines and the co-use of benzodiazepines and buprenorphine. Boarded addiction medicine experts that work with us are on these calls. And then the bulk of the conversation is actually where someone who's part of our community of practice, a program, presents a case, and that case is discussed, and feedback is given on that, and then question and answer. So it's different than just a didactic. It's really about that conversation around patients It also helps to extend supervision of the work that people are doing and provide programs that would not otherwise have access to this type of mentoring. Outlying areas, rural communities, or underserved communities with low access. This really is a way to do that. We also have a major Get Waivered campaign for buprenorphine. And then finally, we have our Texas Substance Use Symposium, which is dedicated to interprofessional learning around improving access to high quality evidence-based care for substance use disorder. So one of the reasons that I got into this work and working and partnering with the state and really looking at transformative change using science is because at some point I just was overwhelmed by the number of pictures of parents holding pictures of their dead children. These are all people, including the woman at the center from San Antonio that I met several years ago at International Overdose Awareness Day in August in San Antonio, who lost her son to opioids and an opioid poisoning. We have to do something differently. We have to keep centering conversations in our country around substance use and the incredible impact that it is having on families and the quality of life of people in all communities, particularly communities of color, particularly in communities that are rural, and particularly in communities that don't have the same access and equitable care and quality of care that others of us do in the United States. So with that, I will stop, and I think I am on time, and we can maybe take a few questions.
Thank you, Dr. Potter, for that informative presentation. And we will now start the live Q&A portion of this webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. We already have some great questions coming in. Our first question, does your use of the term evidence-based mean that there are randomized control trials?
Yeah, that's actually a really great question. And so I'm so glad that it came up. I debated whether to put what I mean by that. So evidence-based care, there are definitions of that. It means that, yes, you do use the best possible evidence available. It's also informed by the clinician's experience and the patient's experience and their desire and their outcomes. So it's patient-centric and it's informed by the science, but it does have that piece of the clinician as part of the decision-making process. Unfortunately, I wish we had evidence-based practices or evidence-based treatments for everything to do with substance use, and unfortunately, we just don't have that. And you know, any randomized controlled trial, when you take it into the one-to-one experience between a patient and a provider, is unique. And so you need to be informed by the science, but you can't just let randomized controlled trials rule entirely. There's also the importance of practice-based evidence. What we learn from clinical experience can be extremely valuable. The challenge is it's got to be informed by the randomized controlled trials.
Thank you so much, Dr. Potter. Our next question coming in, does Texas have a mandatory treatment for SUD/OUD in the prison system?
So not to my knowledge. Actually, it's more the case that there's a greater demand in Texas for treatment in the criminal justice system than there is capacity to serve it. There is a program funded by Health and Human Services, Texas Targeted Opioid Response, that is working in some of the specialized prison systems to expand access to medication. One of the things that underlies that question that's unfortunate is very often when someone enters the criminal justice system, they no longer have access to their treatment. So somebody might be taking methadone, they may be incarcerated for a period of time, and then they don't have methadone anymore, and it actually creates a very dangerous situation when that person is released because they do not have they're at particular risk for overdose and unintentional opioid poisoning at that time because they no longer have the physiological tolerance to higher levels of opioids. And unfortunately, if they do make a decision to use an opioid after release, they'll be at greater risk of death. So no, there is no mandate. So I think I answered that one. I was going to ramble about something else.
Thank you so much, and thanks to our audience for these great questions. Would you talk a little bit more about the stigma impacts substance use disorder treatment?
Yeah. So, stigma is a tough thing. I can't emphasize enough the impact of historical stigma on substance use disorders. One of the most strange to use the word refreshing, but one of the most refreshing things that I've seen actually since about 2016 was that we are increasingly having more conversations around substance use in unexpected places. I do not follow British royalty, but I think it's Prince William's wife, Kate Middleton. That's it. Kate Middleton just recently put out a statement and has taken on talking about addiction as something on her platform. That would never have happened 15 years ago. In the 2016 election, on both sides, we were having conversations around substance use and impacting some of the candidates' lives and their families. And I was watching College Game Day a few weeks ago, and Ashton Kutcher was on there talking about alcohol and that it can cause problems for some, even though he likes to drink. So there's some hope that stigma is starting to reduce. I don't necessarily take on stigma by talking about stigma. What we do in our work is we just do things differently. And that sounds glib, but there's some simple things that we can do in the way we treat people that will destigmatize just naturally. That's why I said, welcome. We're Be Well, Texas, and we're so glad you're here. Because wherever people are, we want to meet them where they're at, and we want to treat them with respect and dignity. But stigma affects us in three ways. There's societal stigma, which we've talked a little bit about. There's stigma from self, and then there's other people's stigma that they press upon you. And so we've even seen physicians who want to treat opioid use disorder who do not treat because they view the other physicians in their practices would judge them negatively for their willingness to treat substance use disorder. So it has a huge impact, and we just have to do things differently.
Thank you so much. We have time for two more questions. Would you comment on the impact of what we are seeing with opioid use disorders and overdose on people with chronic pain?
Yeah. So one of the unfortunate things that has happened with our increased concern around opioid use disorder is that there's been supply side solutions. And so when I say supply side solutions, I'm talking about access to opioid analgesics. So these are those medications that can be diverted, but are actually prescribed to individuals with chronic pain in response to their very real pain. Many individuals with chronic pain have seen a cessation or a dramatic reduction in their access to opioids. It is true that the evidence for opioids to treat chronic pain is mixed, but the way that we have handled this in our country using these supply side solutions really has had some fairly dramatic unintended consequences that have adversely impacted people with chronic pain. They've been considered, speaking of stigma, they've been treated as if they have opioid use disorders when they had no symptom of an opioid use disorder. They've been questioned about their opioid use. They've been judged, and they've lost access much more rapidly than probably would be appropriate. We are seeing some of the consequences of that. So as much as we talk about how we address opioid use disorder, what we're not talking as much about, and I think this is changing a little bit, is how this has impacted people with chronic pain. There are studies going on right now because of heightened concern around suicide and an escalation of suicide in individuals with chronic pain. And one of the speculations is that may be a result of the dramatic and rapid cessation of access to opioids, which they had been using to treat their pain.
Thank you so much. We have time for one more question. As we exit this pandemic, what do you foresee will be the impact on substance use and mental health?
So as I alluded to, we are seeing some warning signs that there has been a fairly significant uptick in mental health and substance use, problematic substance use in the wake of the pandemic. Some have gone so far as to say the next wave of the pandemic is the mental health curve. So we will see this rapid escalation. So there's been some coining of terms like flattening the mental health and substance use disorder curve. People are extraordinarily resilient, and most people, even with an increase in substance use and even with an intermittent issue with a mental health, like an escalation in anxiety or depression or what have you, most people will be okay. And that's a good thing. On the other hand, every life is valuable and precious, and we have to have the infrastructure and we have to have the capacity to be able to serve all individuals who are struggling with a mental health or a substance use disorder. The lack of equity in care is just a terrible issue. The lack of parity that we are still seeing in terms of people's ability to get mental health and substance use disorder treatment relative to physical health issues is significant. And I'm assuming that the folks who took the time to join today are at least curious about how to mitigate that. But I think it's going to be a while. We are concerned and we need to be ready for the problems that are coming, because the downstream consequences could be additional deaths in the wrong direction.
Absolutely. Dr. Potter, thank you so much for your presentation today. Would you like to provide any closing remarks to our audience before we go?
No, I guess I just say thank you so much. I do hope that people will think of this not as an opioid crisis, that they'll think about this as a substance use crisis, and also work to better understand their own personal relationships with substances, including alcohol, in their lives, and approach this from a state of normal behavior, and understand when normal becomes problematic, we need resources and backstops for that. And try to do something differently this week or this month when you run into someone. Rather than judge about substances and substance use, maybe think about a little bit different way to approach it in our own lives as well as in our professional lives.
Wonderful. Wow, thank you so much. And again, thank you for your important research as well. Before we go, I want to thank our audience for joining us today and for our interesting questions we did not have time for today, and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand for 2 years until October 2023. Labrets will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care everyone and stay safe. Bye-bye.